Welcome to the Medisynergy podcast. I'm Imogen, an A-level student here to bring you, the best people with knowledge and insight on how to get into med school, how to become a doctor, and to help you decide whether a career in and around medicine is for you. I'm here today with Catherine Dominic, who is currently studying medicine at Barts and also runs Polygeia, a global health think tank. So listen to find out more about what that is. Welcome to the Medisynergy podcast, Catherine. It's great to have you on here.
Yeah, thanks for having me, Imogen. Great to be here and looking forward to talking all things medicine with you.
Yeah, definitely. So starting with that, basically, why did you want to go into medicine in the first place?
So that's thinking back a long time now to sort of 6 years ago when I applied. But I think the thing that really triggered it for me was obviously really enjoying science in high school. I think that's where everyone starts off. And then I kind of did my first work experience placements in pharmaceutical industry, sort of working on things like supplements and things like that. And I realized that whilst I enjoyed the scientific aspect and things like biology and chemistry that underlie those different streams, I realized that I really missed communication and I really like speaking to people, which is why I then decided to do placements in general practice, in hospital, and sort of volunteer to see whether I enjoyed that aspect a lot more. And I found that I really did. And I thought that medicine would be the perfect combination of those aspects and really bring in both the scientific curiosity, the sort of love for research that I already had at that age, and also the ability to communicate with people, make a difference to people's lives every day. I think something that really stimulated that for me was just having those everyday conversations with people in care homes when volunteering and seeing, actually, I think I could make a really big difference because I think that I enjoy communicating with people and I could use that skill to make a difference and make a benefit. And I also had this very niche interest in sort of international development at that kind of age and global health. And one of the best ways that I thought I could make a difference to that field too was through going into medicine.
Yeah, that's really great. I think it's quite common answer actually kind of the link between communication and science, but it's really good you also have the kind of global health side to it as well. So you're a bit more specific reason why you want to go into it, which is really, really good. And so once you'd decided, okay, I'd quite like to go into medicine, and you decided on Barts, how have you found student life in London?
I think London's a great city to be in. That's for a wide variety of reasons, and that sort of ranges from academic reasons to sort of opportunities, networks, and also obviously all the cultural diversity and everything that London has to offer. I think particularly not growing up anywhere near London, I really threw myself into London life in the first few years because there's just so much to do. It never stops as a city, and that's something that I wasn't used to growing up in a very like sleepy place. So it was really nice contrast to move to somewhere like London. It feels very vibrant, and I think that really keeps you going. Um, Obviously, when you're somewhere for 6 years, there has to be something that keeps you interested and keeps you driven. And I feel like London's atmosphere itself does that. Um, I've also found it really useful to be in London for so many different opportunities. So, for example, some of the things that I've been involved in, like the Chagas Hub, has been very helpful to be in London for. And obviously, my intercalation was at the London School of Hygiene and Tropical Medicine. So that was another great opportunity because sort of my area of interest being tropical medicine, infectious diseases, London's been a great place to be. Even the sort of diversity in the population means that you get such interesting things. So my first ever taster placement in the Royal London Hospital, I was seeing things like neurocysticercosis, which is tapeworm infections of the brain. And you wouldn't think those are things that you'd commonly see in a developed country, but because of the migration, the tourism, and London being so cosmopolitan, you see the coolest things in the city. I think as well, if you want sort of networking opportunities, conferences, so much happens in London all the time. You can probably find a different medical conference to go to every other week. Um, And sort of in my early years getting into research, I really enjoyed going to some of the RSM conferences, events, presenting, and that really helped sort of build a network and meet new people. I think all of that has been sort of really helpful, both for sort of career development and also just to grow and develop as a person, really.
I used to live kind of near London, but as you say, growing up in a sleepy area, it's quite nice to go somewhere where there's a lot more going on and, as you say, very vibrant and lots of opportunities. So that's really, really great that you've mentioned all of that. And you also mentioned about the Chagas Hub. So could you just explain a little bit about what that is?
Yeah, of course. It's not a disease many people have heard of, I think. So Chagas disease is a parasitic disease that's most common in South America. It's spread by the sort of similar parasite to what spreads sleeping sickness in Africa. But Chagas disease manifests in a number of different ways. So, whilst some people get acute illness, the more common way that people present is actually just being asymptomatic, but then later on developing problems with the heart, problems with the intestines, and even problems during pregnancy, which can be fatal to the baby itself. So what we do at the UK Chagas Hub is at the moment, we screen Latin American migrants in the UK for Chagas disease, even if they're asymptomatic, and that's through things like community outreach projects, community screening projects, through working with things like Bolivian dance workshops to get into the community and find a way of reaching those people. Because what we found is there's been a number of studies done in London which have found that obviously migrant populations are quite hard to access and they find it difficult and have a number of barriers themselves to accessing healthcare. So only 1 in 6 Latin American migrants in London are actually registered with a GP, which means that their ability to, find out whether they have this condition and get treated for either the long or short-term sequelae of it are very difficult for them. So that's kind of what the UK Chagas Hub aims to tackle. So we do research, we do screening, we try and influence policy around neglected tropical diseases, and particularly diseases like this in non-endemic settings where often they kind of fly under the radar. But now that the world is so interlinked, um, global health and health security is affected by migration, and that's kind of what we aim to tackle in this particular niche, in this particular disease.
Wow, it sounds really good. And you said about going into was it Bolivian dance classes and things like that, really trying to get into the community. And only 1/6 being registered with a GP is quite shocking, actually, or maybe it's quite common. I'm not really sure, but it's good that you're kind of getting into those communities to spread the word and get people tested for it. And so another thing you do kind of around global health is Polygeia. And so what is the aim of that and how did you get into that?
Yeah, so Polygeia is essentially, to sum it up in one sentence, it's a non-partisan, student-led think tank which focuses mainly on global health issues and policy. And we try to engage students in research in those areas. So that was the overall aim of Polygeia. It was founded a few years ago by a few med students at Oxbridge who were passionate about having a student group that engaged with and contributed to global health policy from the perspective of young people and the next generation to take over in global health and in policy. Um, so that was essentially how it started, and some of our aims are now it's kind of bilateral. So, firstly, to try and deliver high quality research projects. So, each of our research teams is led by at least one postgraduate editor who's got a huge amount of experience in the area and brings together students from a number of subject backgrounds to ensure that you have a diverse range of insights, because global health is so multidisciplinary. That means that we have, anywhere from social science and policy students to medical students to chemistry students, for example. And each of those research areas or themes is commissioned. So we approach different organizations or different professors with their own labs and areas and niches of research to commission projects that they want done with us, and that they these are always people who are also very passionate about empowering the next generation to do this research themselves. And something that we particularly focus on in sort of when I said bilateral, the other aspect being that we kind of want to act as a springboard for the next generation of public health leaders. So it's kind of a unique model in that it allows students to hone their research skills, engage with global health issues, as well as giving them training sessions. So that's something that we've always done as well, is try to make sure that they have the skill set needed to then take away beyond their Polygeia experience and apply to their future research as well. And then we also have a national conference each year, which kind of follows through the research process nicely in that they kind of finish their research project over the summer, and then in the winter term there's usually the annual conference at which they then get to present their work. And something that we are doing a lot more of now is trying to make sure that researchers in what's called the global south, I know it's not a term that I necessarily like, it's just an easy term that people use to kind of describe the global north and the global south, um, that being people in sort of underfunded and lower economically developed countries. We're trying to make sure that we have more branches out there, train more of those researchers so that we can counter the problem that we have in global health of sort of researchers from very developed countries doing the research on less developed countries rather than empowering people in those countries to do it themselves. So that's again something that we're very passionate about and trying to build on for our future aims and goals.
Okay, yeah, that's really great explanation. So just to confirm, you're kind of facilitate, so what you're trying to do is facilitate people in those global south countries to kind of help themselves a little bit.
Yeah, exactly. So yeah, exactly. So we give them opportunities and training, and through those things, they have the experience that they need then to go on to secure, for example, there's a lot more funded PhD opportunities becoming available in those countries, specifically for researchers from certain areas of the world, which is really important in empowering them to do their own research, because ultimately they uniquely know the problems of their own health systems, and someone coming from a UK institution, for example, to do research there can't possibly, produce research to the quality and with the same insight as someone who is from that country. So that's kind of, it's always been a big issue in global health, and that's kind of why there's a lot of movement to decolonize global health and particularly decolonize tropical medicine. Um, because going back to the roots of it, it only originated because, during the British Empire, um, people were worried about the welfare of the British workers who were catching these tropical infections and tropical diseases. So, given that that's the sort of colonial origin of it, it's all trying to sort of divest from that and move away from that in the future, and particularly make sure that there isn't sort of a mismatched power dynamic anymore in research and academia as well.
Oh wow, it sounds quite complicated actually, because obviously there's the geography and the history within it, and then the medicine, and trying not to well, as you say, kind of overpower the other countries and facilitate them doing their own thing rather than kind of doing it for them, so they're dependent on you. So it's really interesting actually. There's a lot in there and a lot that could go wrong, I suppose, and you have to do it right and not, yeah, not dominate other countries. And wow, yeah, there's a lot to go in there. But so you mentioned about how it was originally by Oxbridge students, and obviously you're from Barts. And so how did you kind of get into it, and why were you so passionate about joining it? And do you think being at Barts, with obviously other global health things you're doing at Barts, do you think that's helped you with the running of Polygeia?
Yeah, so starting with your first question and how I got into running it, Polygia operates on a sort of branch basis. So what happens is that there are different branches. So we currently have branches in Oxford, Cambridge, London, and a couple of others in the UK, but then also now in New York, Hong Kong, Ibadan, Nigeria, and Stockholm. So I essentially saw an opportunity. I think I was in my second year of medical school, where they were recruiting for head of policy, which is the person who runs the research project aspect. And I thought, you know what, this sounds like something I'd really enjoy doing. Why not give it a shot? Even if I'm only in second year, my research experience at the time was was limited. I had some, but it wasn't a huge amount. Um, I think I had done maybe one or two research projects by that point, and I had no publications at that point. And I thought, I'll give it a shot. If I get rejected, the worst is that I get rejected. So I had an interview for that, and I somehow managed to get the role of head of policy. So I spent 2 years, my first 2 years at Polygeia, commissioning the research projects. So that was a really helpful experience for me because I learned how to reach out to people, reach out to commissioners, explain things clearly. And that sort of developed both my research skills in terms of developing research projects alongside these commissioners, but also so many different transferable skills like how to communicate better, how to make sure that they're understanding everything that you're trying to say and understanding the aims of the organization if it's not something they've heard of, as well as sort of delegating, thinking about how I could restructure my team, work better with them. I eventually, in the second year, had two deputy policy leads under me who also then helped with the running of these projects and the commissioning of these projects. So that's kind of what I did for the first 2 years. And I also was in charge of recruiting speakers for the conference, usually from the pool of commissioners that we'd had that year. And I did that for 2 years. And then there was an opportunity to apply to become director, which I thought, that would be a really nice natural progression because it's an organization that I care a lot about. I think of all the organizations I've worked with, Polygeia has been my favorite or my pet project, and it's always something that I feel inspired working on. Um, so I applied at that point to become director, and I was appointed. However, I had a bit of a health struggle at that point. I had post-vaccine encephalomyelitis from the COVID vaccine. Um, and I had to actually give up the role at that point. But then the opportunity to take it up again re-emerged a few months later. And I was sort of in the middle of preparing for fourth year, and I thought, should I do it? Should I not? And then I sort of reminded myself of why I cared so much about it. And I thought, okay, I think that just the sort of dedication to the organization will let me drive it properly. So why not? And then I took on the role. I've been director now for almost coming up to a year, and it's sort of a 2 year role. And in terms of how being at Barts helped, I think whilst I applied with very little research experience or just not a huge amount, I had done a lot at Barts in terms of being involved with extracurricular societies and committees already. And that had taught me a lot about leadership and a lot about communicating, a lot about how to just seize opportunities that I was given, because you sometimes go into things not expecting much from those opportunities, and then they end up leading to a lot and leading to really interesting things. So I think that's sort of the mindset that Barts gave me. And it also is it's a sort of university that really pushes you and wants you to do the best that you can possibly do. And I think that sort of mindset really drove me to keep making a difference, in different national committees and in Polygeia.
I think it's amazing about the different skills you've gained from it. You say about communication, leadership, teamwork, delegating, always an important skill. It's really great what you've gained from it and how Barts has helped you with that mindset to just work hard and keep going. And I think that's really, really great. And sorry to hear about your COVID vaccine health problems. It's my next question is related to COVID actually. So you've written a lot of papers and been involved with a lot of research around these kind of things and global health and diseases, and a lot of people will immediately think of COVID, and you've mentioned a bit about COVID there. So has any of your research been around that, or any diseases sort of like it?
Yeah, so my passion is infectious disease research and epidemiology. So I did work on a few projects around COVID. So actually something that we did through Polygeia was during that period, I had the brainwave of starting up a student-led collaborative to try and contribute to the literature in the first phase of COVID because it was moving so rapidly. But then there were so many students at home with like disruptions to their education who had the skill set to contribute that I thought we should harness this power. So we did a project looking at outcomes in patients with cancer and COVID-19, and that was in the very, very early phases of COVID, so in 2020. And that paper has been cited many times in terms of the factors that affect how vulnerable people respond to COVID-19 infection. So that was sort of one of the first COVID-y projects. And I've also done a few other projects on COVID in terms of the larger scale impact of COVID on health systems and health infrastructure. So we had a collaborative, for example, looking at the impact of COVID on pediatric cancer surgeries and how that affected outcomes for patients, as well as on how COVID had affected elective procedures in urology in the UK and particularly for renal stones, and how that had also affected patient outcomes. I also did a little bit of work on how COVID had affected medical education because, as you can imagine, there was a huge amount of disruption during that time. And even in the year following, a lot of things were online. And I think medicine's a subject that's very hard to teach online. So we did a couple of bits on looking at how, firstly, how the interim FY1 year affected students going into foundation and whether actually is that something that might be useful to have in the future anyway. And also things like how ready students felt despite the disruptions to their education in terms of starting foundation placements. Another COVID related thing was looking into remote health. So I think that something that I've found is whilst I enjoy infection, I also enjoy a lot of different things, which is why even during COVID, I tried to look at it from different angles in terms of like education, impact on surgery generally, and then this one, which was kind of more med techy. So we realized that there was not that much literature looking at how you can remotely assess how bad someone's COVID is. And we realized that that wasn't actually just in COVID, it was in lots of respiratory conditions. So, for example, if someone's having an asthma attack and you're the GP on the phone call, how do you know how bad that asthma attack is? And, it's very difficult. So, we did a systematic review of papers looking at remote risk stratification of dyspnea or difficulty breathing in acute respiratory conditions. And that, though it started from COVID, is very applicable to sort of the broader applications of medtech and remote healthcare in the future, which I think is the future of medicine, really. Whilst I've done a lot on COVID, it's not my primary interest. My primary interest is something called neglected tropical diseases. So this is a group of diseases which are so-called neglected, which means that they don't get much funding, much attention, much policy discussion, despite the fact that they affect more than 2 billion people worldwide. And they sort of drive communities to live in vicious cycles of poverty. So when I said I had my first interest in international development and global health back when I applied for medical school, I realized that a huge amount of that is actually due to things like neglected tropical diseases and communicable diseases, which are so easily cured, which is why I think that they should be a really big priority in healthcare. Because, for example, in the last century, trachoma, which is a type of chlamydial infection, was the leading cause of blindness from infection in a number of countries, and particularly developing countries. However, the administration of just a single antibiotic has massively reduced the rates of that, reduced the rates of blindness, improved outcomes, not only for health in populations, but also for things like children going to school and getting an education and then being able to provide for their families. That's the kind of knock-on effect that infectious diseases have. So some of the things that I've worked on include NOMA. My master's dissertation was on a skin disease called yaws, which is also a neglected tropical disease. So that's my main area of interest, really.
So that's really, really great. And also how COVID has affected medical education. I think a lot of people talk about on the podcast because they always go, well, the first 2 years or like the middle 2 years of med school was affected by COVID, and as you say, it's very hard to teach online. So yeah, it's interesting to see how that's affected people, and it'll be interesting to see how it affects the kind of next batch of junior doctors and doctors. So yeah, it's really interesting to see how, well, in our case in the UK anyway, how just one infectious disease can have such a big impact. But then also you're talking about these other neglected tropical diseases that don't get the funding that COVID's had and don't get the attention, but are still having such a big impact. I just haven't heard that much about it before, and it's really good to learn about it and that you're talking about it here. And 2 billion people as well, if that's the kind of classification, it's affecting that many people and it's not getting enough attention, then yeah, it's really important to have a look at it. Definitely.
Yeah, I think something that people kind of forget is that if we're going to develop as a planet, it's not just about the West developing and leaving everyone behind. It's kind of making sure that everyone develops and progresses together. And I think a huge aspect of that is health, which is why I think global health as a concept is so important.
Yeah, definitely. And it's just reminding me of doing geography last year about how even the smallest thing can make such an impact to development. And obviously health is going to be a big one, because if people aren't healthy, they can't make new buildings and make schools and teach and all this thing, and it has such a big impact on that whole country and then all the countries around it and everything like that. It's just amazing that one thing can make that much of an impact, but improving it can obviously develop that country quite a bit more. So yeah, it's really, really interesting. So with that, you've mentioned about how just one antibiotic can really improve the effects of different diseases that you've mentioned there. But how, it's a very broad question, but how can we improve global health?
Yeah, it is. It's a huge question. I think people have written whole books on the topic. And I think I can go into a little bit of sort of briefly how we can. So, like you mentioned, a single antibiotic, and that comes to the issue of access to medicines. That single antibiotic was able to be distributed because the pharmaceutical industry donated that for years and years in order to tackle this particular infectious disease. And that is actually something that they do for a number of these neglected tropical diseases. Um, However, access to other medicines in developing countries is still limited, and things like patents and things like the regulations that surround the pharmaceutical industry um, do mean that we kind of hold various countries back in terms of access to medicines. And when I say access to medicines, I don't just mean tablets, pills, I mean medical devices, so insulin injectors. I mean things like the COVID vaccine. We've had huge discussions about vaccine inequity and all of the problems around that, and how that means that, you know, we're not attaining a certain global level of immunity, which we need given how globalized and connected the planet is. And that kind of stuff is really important. So working towards universal access to medicines, which is something that an organization called UAEM does a lot of work on. So that's Universities Allied for Essential Medicines. Um, and they do some really great work on sort of campaigning with the pharmaceutical industry, trying to work with them to come up with more equitable solutions for improving access to medicines. You've then got, you know, some of the way that you can think about improving global health is kind of thinking about the building blocks of UHC. UHC is universal health coverage, and that is something that every health system on the planet tries to achieve. Personally, I think that the NHS is one of the greatest examples of UHC being free at the point of care, and providing equally for people. So it really goes with the ethical principle of justice that you know you talk about in medical interviews, because no one's denied care or discriminated against in the NHS. And that is because of the fact that at its start, it had all of the building blocks of UHC, which is things like a very strong health infrastructure. So the structure is very well thought out and very planned. And in terms of the way that it's funded, it's sort of publicly financed And I think that's really important, but it's important to think about the sustainability of that. So that's really important, sort of financing health and how much of a national priority that is in various countries really affects global health, as well as things like the training of the workforce. So obviously doctors and nurses are a huge part of the health workforce, and there are, various issues with access to medical education, quality of medical education, in various countries, and uniformizing that as well is part of improving global health. I think, like you said, there's so much to say about it, and it's so multidisciplinary. It requires a multi-system approach. It needs people in policy, people in science, people in medicine, people in technology to come together to think about what we can do to drive it forward as a movement in terms of improving global health, because it's not just something that happens in one country. It's global, and that's why organizations like the World Health Organization are so key in producing uniform policy and uniform discussion on how we as a planet can progress.
Yeah, wow. You mentioned a lot there, and as I said, it was quite a large question, so it's got to have a large answer. But I just want to pick up on something you said there. Within all of that, you said how the NHS is a great example of a UHC and how it's not discriminatory and free at the point of service and all of that kind of thing. But earlier you mentioned how I'm pretty sure it was South Americans. There's only 1/6 of them registered with a GP. Do you think there's any reason for that? Do you think maybe the NHS is not meaning to be, but people are less likely to register with the NHS GP for any particular reason?
I think, I mean, there are a number of issues with the NHS that we're seeing now. I think when it was designed, it was definitely probably the world's prime example of UHC back in the 1940s. Now there are a number of barriers to accessing the NHS and accessing healthcare, and that does particularly manifest in vulnerable populations. So, um, like I mentioned to you earlier, I'm thinking about doing a sort of perception study, and looking at why there are those barriers in Latin American migrants in the UK. Um, but some of the things that I can say off the top of my head are, the NHS isn't the friendliest place necessarily for undocumented people and people living in the UK without a registered status, and that does put people off, for example, applying for a GP registration because of all the paperwork you need to fill out, all the proof of ID you need to submit. And that sort of, it seems like an administrative barrier, but even that limits health access so much. And it's really important to be aware of how all of these small things cumulatively add up to being a barrier to health access. I think, given how much more globalized the UK is becoming, migrant health is a huge area that we need to be really mindful of going forward. Not just for things like communicable diseases, but because migrants coming into the UK have a different profile of non-communicable diseases as well, but depending on, for example, their diet and things. And, even sort of the differences in vaccine perception in South Asian populations. With the COVID pandemic, we saw a lot of vaccine hesitancy initially, and it took sort of breaking those barriers down with cultural and language friendly interventions to be able to get them up to the same levels of vaccination, and reduce that hesitancy. So I think that's kind of what's needed in the NHS now is partly to be, more mindful of the vulnerable populations that might be getting missed out of various things. I think I would still say it's a really great example of a health system. Unfortunately, without the funding it needs, there's only so much it can do. And that's sort of the really unfortunate part of it, is that ultimately it all comes down to being limited by resources. And that's the main, downfall, unfortunately, of the NHS is if you don't have enough money, there's only so much you can do and so many people you can reach.
Yeah, that's a really great explanation. Thank you so much, because it's just interesting to see what's happening with the NHS at the moment, as you mentioned, and all these different barriers that can come up that you might not think of if you've always lived in the UK and always been part of the NHS and had a GP. And you clearly know your stuff, you clearly know what you're talking about. So to finish off, what would your tips be on how to get to where you are today?
In terms of where I am today, I'm not sure I like that phrase because I've got so far to go. But in terms of how to seize opportunities, I've got a few tips. So the first one I would say is to say yes to everything that you're offered. Um, whilst there is a balance there, and I'm not saying say yes to everything to the point where it affects your exams and you can't do any actual revision, I'm saying seize the opportunities that fall into your lap and also be proactive with seeking opportunities. That's something that I found so helpful in terms of just putting myself out there and saying, emailing researchers and saying, I'm really interested in this and I think I could really make a difference. I've got this skill set that I've taught myself, and these are my past experiences. Can I help with any of the work you're doing? And that's got me so far in terms of, so many of the research projects I've done have been through reaching out to people who I didn't previously know or hadn't previously met. And then they'll say something like, let's set up a meeting, let's discuss. And then you form a partnership and a network, and a bond through that for the rest of your career, even. You develop really important mentorships. I think that's something that's really important as well, is finding good mentors who inspire you, motivate you, and who you would like to be like, because that gives you almost a blueprint of your future of, I want to be just like you. I find that you make so much of a difference. And sort of that was for me, that's my master's dissertation supervisor, who is an incredible academic researcher and incredible clinician, and really gives me an idea of what to strive for. My second tip is something that I was told very early on in my research career, which is never be the rate limiting step, which essentially means in any endeavor that you do, don't be the person that holds back the progress, or don't be the person that everyone's waiting for. Be the person that's proactive, does your jobs, drives everything forward, and inspires, the rest of the team around you, so that everything, gets done in time. Um, and then finally, the third one is to try and find your balance early. I think it's something that I still struggle with, but I think that finding it in medical school is a good foundation, a good footing for the rest of your career as a doctor. Finding that balance between this is where my professional and academic life stops, and this is where my personal life is, and not allowing, both to blend into each other. So I know lots of people will still answer their emails at 11 p.m. or be doing work like late into times that they should be doing other things. And I think it's really important. I know people say a lot about work-life balance when you're applying to medical school and in your interviews, but it is something that is so important and so easy to forget when you get overwhelmed by medicine, because people see it as a vocation and they think, okay, it's not a job, it's a lifestyle. It is a lifestyle, but it is also a job, and there is a place where that job stops. I think starting that mindset in medical school will make you sort of healthier in your approach to the whole career moving forward as well.
Wow, that's really helpful. Thank you so much. So we've got say yes to a lot of things, but obviously within reason. Go and find a mentor that you kind of want to be like in the future, and never be the person that holds back progress. I really like that one because it kind of makes you think, no, come on, get on with it. Don't hold everyone back and don't hold yourself back as well. And then finally, find your balance early. And I really like that how you said it's not a lifestyle, it is a job, and you can obviously have a bit of lifestyle around it, but ultimately it's not your whole life. It is just a job in the end and just a degree. So it's quite interesting to see that point of view. So thank you so much for being on the podcast today. It's been great to have you.
Yeah, thank you for having me. It's been really great to talk to you. I feel inspired going away from it too, knowing that, people like you are the future of medicine as well.
Oh wow, thank you. Yeah, I've learned so much. It's been really, really great. So that's all today from the Medisynergy podcast. Thank you for listening, and join us next week, and make sure to recommend this episode to any aspiring medics.